Kia ora everyone, and welcome to our Goodfellow webinar on heart failure therapy. This episode is kindly supported by an educational grant from Lily and Boehringer Ingelheim. The content is entirely independent and was developed by the Goodfellow Unit and our expert speaker. I'm Dr. Louise Kugler from the Goodfellow Unit, and tonight I'm talking to Professor Rob Doughty. Rob holds the Heart Foundation Chair of Heart Health at the University of Auckland, where he runs a program of research relating to improving the understanding of the causes, prevention and treatment of heart disease in New Zealand. He is a cardiologist at the Green Lane Cardiovascular Service, Auckland City Hospital and the Heart Group. His current research interests include the genetic and environmental causes of premature coronary disease, cardiovascular risk management, outcomes and innovative therapies for patients with heart failure, atrial fibrillation and coronary disease. I'd like to hand over now to Rob. Kia ora, Rob, and welcome.
Kia ora, Louise, thank you very much, and thank you for this invitation to speak. So I will just share my screen. So good evening, everybody. So I will spend the next few minutes really talking about heart failure, particularly orientated towards therapies and what's different, and hopefully some practical aspects that will help you in your clinical practice. So this is really what I aim to cover. So I'm just going to do a quick context of heart failure from a New Zealand point of view, and I'm going to use a couple of cases for that really, which will also come across some of the definitions that we'll revisit simply because it's important in relation to the therapies. I'm going to talk a little bit about Sacubitril valsartan, its role, and importantly then some practical tips for the safe use. But most of the time I'll spend really talking about the SGLT2 inhibitors, for which we now have extensive evidence, and I'll try and wrap that back into the clinical context at the end. So that's the next few minutes. So thank you for this invitation again. So you'll be very familiar with this kind of context. So here's two patients with heart failure. These patients are obviously very different. You can spot that from the end of the bed because one's 35 and one's 78. But for all intents and purposes, these two patients will present to you or to hospital with the clinical syndrome of heart failure. And that clinical syndrome may not be distinguishable at the bedside across the spectrum of what we'll talk about today. So these two patients, these two individuals were hospitalized with heart failure. They both, by definition, most of the time, those hospitalized patients had class 4 symptoms, so that's symptoms at rest or with minimal exertion and or at night. And they had the clinical signs of heart failure. Both had elevated NT-proBNP levels on admission to hospital in the several hundreds. And so from a diagnostic point of view, that in that context is, I would say, relatively straightforward. It certainly fulfills all of the standard definitions for diagnosis, which includes the context, the symptom presentation, the clinical signs, and then these days an NT-proBNP level. So these two patients really both have the clinical syndrome of heart failure. They are, though, and this will be no surprise to you, they are both very different in the phenotype of the expression of heart failure that they have underlying that clinical syndrome. So the younger male has a severely dilated left ventricle with very severe left ventricular systolic impairment with an ejection fraction of 15%. And the lady has a small ventricle with normal left ventricular ejection fraction, and she has LV hypertrophy, so perhaps the substrate for a stiff ventricle that's not relaxing properly. So same clinical syndrome, same clinical presentation, but fundamentally very different in the characteristics of those individuals. You're very familiar, I know, with this kind of schema for the ejection fraction phenotype of those individual patients. So those people with a lower ejection fraction, termed heart failure with reduced ejection fraction, or HFrEF, and then those with higher ejection fraction, over about 50%, usually is the cutoff, termed to be HFpEF, or heart failure with preserved ejection fraction. So those definitions really have been around for a long time now, but have subtly changed. And what's been introduced really in the last year or two is to introduce that group of patients with an ejection fraction between sort of 41 to 49%, as described as mildly reduced. You may argue to say, well, actually, does that really matter? It matters because these people in that range, if they're starting with that kind of descriptor from an ejection fraction point of view, the therapeutic trials for all the benefits that we know for people with reduced ejection fraction have generally involved people below 40%. So the mildly reduced EF characterizes a subgroup of patients where we have uncertainty about therapeutic implications for various therapies. So that's really been the driver to add a third group, not to make our life difficult, but to put in that uncertainty for what that means for those individual patients. So where are we at in New Zealand? Many of you will have seen some of this data previously. So in the 2000s and through to around about 2012 or so, what we were seeing generally was a decline in the incidence of heart failure. So the incidence each year was just quietly going down, perhaps driven in particular by the improvements in outcome for people with coronary artery disease. So the ischemic heart failure context becoming less common, and consequently fewer people developing heart failure on the back of their coronary disease. Rather troubling though, since it's really 10 years now, what we've been seeing is a gradual increase in heart failure incidence in younger people. Here on these slides, the red dots are those people with non-ischemic heart failure, and the blue squares are those with ischemic heart failure. So you can see there overall, and there that's 20 to 49 top right, 50 to 59, 60 to 69. You can see that upswing in the incidence of the non-ischemic etiologies occurring in those younger people. So that's rather troubling when in those, what I'll perhaps describe as working age years, we're seeing a shift in the etiology of heart failure, and not just a shift, but an increase in incidence for those non-ischemics. We don't truly understand quite what's driving that at the moment, and it's probably a multitude of factors, and very happy to talk about that in questions if you'd like to. What's the overall outcome for people with heart failure? Those with reduced ejection fraction, it remains to be poor. So New Zealand data from a few years ago, a 25% mortality rate by 2 years after diagnosis. So that's a high mortality rate, and that continues up to where we are at this point. You're all very familiar with background therapies that we've known about now for several decades, and these have changed the outcomes for people with heart failure. So people of my sort of age will remember having a patient on a ward as a house officer with bad heart failure, class 4 heart failure. And when we started using ACE inhibitors, actually seeing those patients being able to get up and walk around and potentially leave hospital. So these sort of therapeutic interventions have been with us for a long time. This is for those people with reduced ejection fraction. So that background ACE inhibitor, beta blocker, spironolactone, plus their diuretic, their furosemide or bumetanide, whichever is the choice of the day, that sort of therapeutic armory, if you like, has been with us for a long time. And I'm not going to talk too much more about those specifics today, but again, happy to answer questions on those as you see fit. What I would like to do is move to probably the two newest therapies and spend a little bit of time on those with some detail. I do need to show you a little bit of data, but I'm going to keep it kind of summarized. So this isn't going to be swamping you in masses and masses of trial data, but enough that I hope that I can convince you that we really are about to embark on quite a different era for heart failure management. First is the angiotensin receptor antagonist neprilysin inhibitor, and that's a combination therapy, as you know, and the terminology often is ARNI. So you'll hear Arnie, and I'm sure you're using that yourself. The one agent that we have in this country, obviously, is Entresto. So I may just use those names interchangeably in the next few minutes. So what is this drug? Well, this kind of is a schema to illustrate this. On the right-hand side is the renin-angiotensin system that you're very familiar with from the ACE inhibitor and angiotensin receptor blocker days. And the agent in that combination drug is valsartan. We haven't really used valsartan in New Zealand context particularly much over the last few decades, but it is interchangeable with candesartan and losartan that we're all extremely familiar with. The additive benefit is this drug called Sacubitril. And what it does is to inhibit the breakdown of brain or B-type natriuretic peptide. So we use that as a diagnostic tool, which we've just talked about in those two cases. But the B-type natriuretic peptide is released in heart failure, and it functions as a vasodilator and causes natriuresis and diuresis. So in inhibiting its breakdown increases those physiological effects of naturally occurring BNP and enhances that pathway. So this combination drug obviously then is actually a combination, it's a polypill effectively, of two agents that are addressing two pathophysiologically different pathways in the heart failure context. You know about where the data comes from. This is now going back, going back 8 years now, so back to 2014 when the Paradigm HF trial was published, that basically showed superiority of Entresto over standard background therapy with the ACE inhibitor enalapril. So a clinical endpoint benefit of a reduction in mortality and of hospitalization for heart failure with a low number needed to treat over only a couple of years. So this really was, I hate to use the word game changer, but it certainly was a game changer in that sort of context. And so this agent has then become, has a class 1 recommendation in standard guidelines, and it's recommended as a replacement for ACE inhibitors to further reduce the risk of heart failure and death in those patients who remain symptomatic despite optimal therapy, and that's optimal full background therapy. So that's how our special authority criteria are. That's the guideline recommendation, but our special authority criteria for Entresto actually mirrors that. So the context is right, I think. Obviously, special authorities we can discuss if you'd like to at some point from the point of view of limiting access, etc. But this is where we are with Entresto. So this has been around for a little while, and now we've been able to use this for a few years. A couple of years ago, the heart function team that I lead at what was Auckland City Hospital looked at the first 50 patients that we transitioned to Entresto. And so this was unselected patients. This were patients who were coming through our service, and we were addressing their standard heart failure therapies, and we got on and transitioned them to Entresto. So wide age range, 27 to 83. So we certainly aren't ageist. And 58% of those patients were non-New Zealand European. And our criteria that we really pushed at that time was to ensure that we had indeed got these patients onto standard therapies. And indeed, certainly our brief at that time was to titrate dosages to maximum tolerated dosages before we made a transition as well. So these were very well treated and titrated onto those standard therapies. We were able to switch patients over, and the overall reduction in blood pressure over and above where they had already got to with their blood pressure reduction with those therapies was an extra 10 millimeters of mercury systolic. In the trials, it was reported to be about 4 millimeters of mercury. So this was quite a profound reduction in blood pressure that you achieve in this change from your background standard therapies to Entresto. So kind of don't underestimate that degree of reduction in blood pressure that you achieve. But with the care that was taken to do this, we were able to maintain the vast majority of those patients on mid or high dose Entresto. And again, that was our policy of not accepting low dose, but to continue to push dosages. These drugs are well tolerated if they're transitioned, I'll say appropriately, but transitioned carefully, being aware of the reduction in blood pressure, and actually often being proactive about reducing the loop diuretic as you go to Entresto. And again, we can perhaps come back to some of that sort of in question time. So you do need to think about it. You do need to change other therapies, particularly the loop diuretic, and you can achieve this in many, many patients. Other side effects are generally uncommon. We've had 1 or 2 people with GI-related disturbance symptoms, diarrhea, for example. And the other factor to look at is abnormal liver bloods. These patients need monitoring, they need their renal function, they need the liver bloods checked, and they need their blood pressure checked. So a transition point certainly requires follow-up. And we found that these patients needed about an extra 3 visits or healthcare contact points to get to the dosages that we finally achieved. So this really has become a very standard part of our approach now. You will see some of your patients who have been admitted to hospital with de novo heart failure and are being sent out on Entresto. So some clinicians are taking a very early approach to the use of Entresto, perhaps only a few days of standard therapy in hospital, and then doing a transition to discharge. And again, you can argue the benefit or not of doing that. I do have a few concerns about that happening too often and systematically, particularly from a hypotension point of view at that stage, but it is possible. And so you will see patients who appear to have had a very recent diagnosis of heart failure being discharged and coming out on Entresto. And most of the time you'll find that that will be on low dose Entresto rather than higher dosages. So a very important part currently of what really now we need to consider as standard therapies. So I'm going to spend the rest of the time really talking about the SGLT2 inhibitors. You'll be familiar with these, I know already, from many angles, from a diabetes management point of view, as well as from a cardiovascular point of view. So I guess just bear with me a little bit. I will share with you some new data just from last weekend when we get there. So I think it does really get to a stage now where it completes the circle of information for the SGLT2s from a heart failure management point of view very, very nicely. The evolution of the data has been very fast in only a few years, but these agents were actually first identified back in the early 1990s, and were originally an isolate from the apple tree bark that was seen to be glycosuric. So obviously a lot of development obviously gone on since then, but the actual agents have been around for a while. But the story behind this evolution from a heart failure management point of view is quite an interesting story. So let's back up a little bit. So sodium glucose co-transporter 2, that's the SGLT2. These are proteins. They're expressed in the proximal tubules of the kidney, and they're responsible for about 90% of filtered glucose reabsorption. And that response is maladaptive in people with type 2 diabetes, so that the SGLT2 protein system is maladaptive and consequently contributes to the hyperglycemia of diabetes. And I think that's obviously where the initial particular focus of interest came with the SGLT2s. And they were shown relatively early on. The SGLT2 inhibitors were shown to prevent reabsorption of glucose and facilitate excretion of glucose in the urine. Obviously from a pathophysiological point of view, doing what you'd expect them to do, and along with that, improving glycemic control. So that's the, I guess, quick summary of the diabetes context, which led to the large trials for people with diabetes. But what we need to be aware of is, why did the data come out in relation to the benefits in relation to heart failure? Well, in 2008, the Food and Drug Administration in the US provided guidance for industry in relation to the process for pharmaceutical companies who were developing new therapies for patients with type 2 diabetes. And they put out various statements, and this is a quote from one of them, that the sponsors should demonstrate that the therapy will not result in an unacceptable increase in cardiovascular risk. And this was led from some prior therapies that had appeared to increase cardiovascular risk. So this was a safety signal, really, to say that the FDA was going to say that if you had your new drug for treating diabetes, you had to be able to demonstrate that there was not an increase in cardiovascular risk. So of course, that was a strong driver to ensuring that trials were large enough and collected the correct information from a cardiovascular endpoint point of view when they were addressing the context for patients with diabetes. And you'll be familiar with a number of these different studies. And so there were these are SGLT2 inhibitors in patients with diabetes first and foremost, of which some had established cardiovascular disease and some did not have known cardiovascular disease. And this was a meta-analysis from 4 years ago, just demonstrating really that that was the first signal here that there was a reduction in the risk of patients dying or being hospitalized with heart failure with the background of cardiovascular disease in these diabetes trials. So the FDA had put the word out to say, you've got to demonstrate that your drug does not increase the risk of bad cardiovascular outcome, but in doing so actually triggered the collection of this data from these large-scale trials demonstrating that actually the SGLT2 inhibitors actually improved outcomes. So a bit of serendipity, I think, along the way in the evolution of our understanding of these agents. So this is, remember, this is now just the trials with diabetes. Recognition of the benefit in reducing heart failure hospitalizations very, very rapidly led to the development of the heart failure trials that we'll walk through in a second. So that's the context. It led from the research in those people with diabetes. But what I'll talk through now is the effect for the patients with heart failure, whether or not they have diabetes. And that's an important factor to remember, especially when we get to clinical utility. So what I've done here is just put on this the ejection fraction phenotype that we talked about at the beginning. And here just focusing on those people with the heart failure with reduced ejection fraction, and 2 trials. I'm not going to spend too much time on these trials. These are a little bit older now. So they're 2 and 3 years old. We have DAPA-HF with dapagliflozin and EMPEROR-reduced empagliflozin, both 10 milligrams per day. These were clinical endpoint trials, and these were patients with heart failure with or without diabetes. A meta-analysis is probably the easiest way to summarize these 2 studies. So this was a meta-analysis of the 8,500 patients across those 2 studies, and clearly demonstrating a reduction in total mortality, reduction in cardiovascular death, and a large reduction, a 31% relative risk reduction of heart failure hospitalization. So this is in patients with established heart failure, showing that reduction in the heart failure hospitalization. And remember, from a clinical angle, from a clinical impact point of view, heart failure hospitalizations are never a good thing for a patient to have. They're associated with obviously a lot of morbidity for the patient, and then subsequent mortality and subsequent readmissions. So heart failure hospitalizations are a very important sequential event in the life course of a patient with established heart failure. So that's the heart failure with reduced ejection fraction, 2 major trials, very convincing data. What evolved again, very quickly, if you look at the years of publication, is the 2 trials for patients with an ejection fraction of 41% or higher. So what we might have termed just the HFpEF group, but that includes what I described earlier, this mildly reduced ejection fraction as well. So Emperor Preserved, published last year in 2021, and the Deliver trial with dapagliflozin, and this was presented at the European Society of Cardiology meeting on this last weekend and published concurrently in the New England Journal of Medicine just a couple of days ago. So 2 very, very important trials. And I haven't gone into the context of the HFpEF pathophysiology, but to summarize that, what we've had in the past is that all of the therapies that have been used for patients with a reduced ejection fraction have basically been trialed in those with preserved ejection fraction. You don't see the same benefits. So the ACE inhibitors, angiotensin receptor blockers, the spironolactone, the beta blockers do not have the same benefit, probably reflecting that the HFpEF patients are a very heterogeneous group of patients with a lot of different underlying etiologies, a lot of different underlying risk factors, and consequently their pathophysiology is different. So these are very important from the point of view of the clinical implications of what's next for this group of patients, which in most cohorts, and certainly in New Zealand, this will be about half of all the patients that we'll see with heart failure. So to walk through these relatively briefly at sort of high level, so these are what I'll call the HFpEF trials, excepting they include the mildly reduced group. Emperor Preserved, published last year, ejection fraction of more than 40%, symptomatic heart failure, and a simple empagliflozin 10 milligrams compared to placebo. And that's the clinical benefit, so a reduction in the risk of cardiovascular death or heart failure hospitalization, reducing from 17% to 13.8%. So adequately powered, large-scale trials demonstrating the clinical benefit of empagliflozin in this clinical context. And then published on the weekend is the Deliver trial, which you could almost mirror those cumulative event curves that I've just put up there for you to see. Slightly different event rates I'll come back to in a second, but again, demonstrating now with a different SGLT2 inhibitor that clinical endpoint is less frequent compared to the placebo for the same patient group. So putting those 2 studies next to each other, large-scale clinical endpoint studies, 2 different SGLT2 inhibitors, which I always think is important in these sort of contexts. Is this a class effect or is this an individual agent? So now we've got the 2 agents, the same primary outcome, worsening heart failure or cardiovascular death. And I've just put in there the placebo event rate, and that's over an average of just over 2 years. So this is a very high event rate, from 19.5% or 17.1% for those 2 trials. So these patients they don't have a benign disease. They have a disease associated with high morbidity and mortality over the years ahead. Very, very similar hazard ratio for the benefit of those drugs in those 2 trials, and the numbers needed to treat almost identical, of around about 30, 31, 32 for each of those 2 studies over a couple of years to prevent one of those events occurring. So very, very, very similar results, and very reassuring, I think, in the context of the data that's behind them. So if you pull all that together, where do we sit now? So we sit now, as of kind of this week, if you like, in quite a different place to we have in any time previously. We have 2 large-scale trials in each of the major ejection fraction phenotypes with the SGLT2s, both different drugs in each of those EF groups, and with highly consistent effects, treatment effects of those agents. It's the first time that this has ever been demonstrated for any therapeutic intervention for patients with heart failure. So this is not an ACE inhibitor story or an ARB story or a spironolactone story again. This is a very, very important time point, I think, in relation to heart failure management. To put it all together, you can actually incorporate all of those trials together in a meta-analysis, and that's what, as I'm sorry I didn't put on here the publication, this is from the Lancet this last weekend, and just very, very nicely summarizing that data set of those HFpEF and HFrEF trials. And I think those plots really very nicely demonstrate the consistency of the treatment effect of those therapeutic interventions across that range of ejection fraction phenotype. A recurring question has been, well, how do these drugs work? And we know about the glycosuric effect of the drugs. The blood pressure reduction of these drugs is very, very small. It's about 1.2 millimeters of mercury systolic blood pressure reduction. So their blood pressure lowering effect is pretty small compared to most of the other therapies we would use for patients with heart failure. And it is very likely that it is a multitude of effect that has the effect. In a way, if you could reinvent all of this, you would not, clearly you would not start with diabetes, you'd be starting with cardiovascular disease in this kind of context. And this is a really nice review from Nature Reviews a couple of years ago now, but just trying to sort of postulate where the pathophysiological benefits are. Is it a hemodynamic benefit, natriuresis, reducing fluid overload, reducing the standard risk factors, including the diabetes, but direct myocardial effects are certainly highly possible as well, and perhaps sort of off-target effects that we weren't really necessarily aware of when we focus on the SGLT2 inhibitor itself. So there's the sodium hydrogen exchanger, that's the NHE1 on the left-hand side there. That exchanger is in the heart. There's NaH3, which is the sodium hydrogen exchanger in the kidneys. So there's a multitude of other effects that are perhaps off the classical target of what you might think these drugs do. Do we actually know how they work? No, we don't. But clearly what we do know is we know the clinical benefits and we know the consistency of that. So where does standard heart failure guidelines fit in for the recommendations of these drugs now that we know this evidence? This is the European Society of Heart Failure guidelines that were revised last year, 2021. And in that, for the patients with HFrEF, the dapagliflozin and empagliflozin get a class 1 recommendation for that indication. So that's those people with reduced ejection fraction. At our Cardiac Society meeting a few weeks ago, we had one of the, or the principal author of the European guidelines come out to our meeting in Australia, and really was able to articulate very nicely where all this fits in, but also to remind us that actually this evidence has accumulated very, very quickly, including within the last year. And so the HFpEF data that I've just shown you, including only data from last weekend, clearly was not available at the time that these guidelines were written. So the focus there really was on the HFrEF situation. If you think about HFrEF, then is this a drug that we're going to use? Are we going to use it a lot? And so the Get With the Guidelines registry in America, in North America, has been a very useful source of sort of understanding where new therapies will fit in, as well as uptake of therapies. And so this group of authors looked at their data set of patients with heart failure in this registry and applied those inclusion criteria from the HFrEF trials that I just showed you just now, and commented that 4 out of those 5 patients of those patients would be candidate for dapagliflozin or in fact empagliflozin. So very, very high potential use across patients with HFrEF in this clinical context of this example And remember, this is regardless of diabetes status. This is first and foremost about their heart failure. So coming back to the ESC guidelines, this I'm pleased to see is a very simplified management sort of flow chart, but just look at the big green box at the top, and you can see here that now these agents that we've just kind of gone over really are all lumped together there in the standard management for HFrEF. So ACE inhibitor, and then transition to ARNI, Entresto for us, a beta blocker, a mineral receptor antagonist, mineralocorticoid receptor antagonist, so for us, mainly spironolactone, and then either dapagliflozin or empagliflozin, and as well as your loop diuretic for your congestion. So that green box really is putting all of that now. We must consider these drugs as disease-modifying drugs. That's how we talk to patients about it through the heart function service that we run. These are disease-modifying drugs, and the implications of being able to use all of these classes really are quite profound for patients with what otherwise, as we know, is a very bad condition. I'm going to skip that slide. So I'm going to come back here to our two patients that I started with. So on the left-hand side there, the 35-year-old male with the reduced ejection fraction, with a very low ejection fraction. So he would be eligible, and in fact, guideline recommended therapies would include those 4 classes of medications. And so from our point of view, for the classes that we would commonly use, we'll be on Entresto, bisoprolol, spironolactone, and now empagliflozin. What's the point of doing this? Is it really, really beneficial? And I think this is a really, really elegant piece of work that, again, now is a year or 2 old. But this was about putting the context of these combined therapies compared to what we used to use, which was just an ACE inhibitor and a beta blocker. And so just look at the curve on the right-hand side there, the top one, for example. This is, in the blue, is the combined therapies that I've just talked about, including the spironolactone and empagliflozin and ARNI. And these are event-free survival. So the red curve, you can see that there's a rapid accumulation of events occurring across compared to those combined therapies. And so if you took a person who's 55 years old, you're talking about an additional 8+ years of event-free survival with that combination therapy. So that really is a very profound treatment effect for what otherwise is the very important condition that we know about. And this was just their comment really that you can read, but really just reinforces my comment that this is disease-modifying pharmacotherapy. This isn't dabbling around with improving someone's symptoms for a little bit of period of time. This is fundamentally altering the disease process for these individual patients. Getting towards the end, so coming back again to our 2 cases. So the other patient was a 78-year-old female, also in hospital with heart failure, with HFpEF. So she had a preserved ejection fraction. So our standard therapies would be diuretic therapy and then management of comorbidity. So focusing towards perhaps what are the underlying conditions and risk factors that result in this condition. Because we know that the other therapies we use that we've just been talking about really don't have systematic clinical benefit. So it might be, she might be on an ACE inhibitor because of hypertension. She might need therapies for diabetes. So there might be a whole host of other medications she's taking. But based on the data we've just been looking at and reviewing, then now she's clearly indicated is for empagliflozin to be added to her therapies for clinical benefit for the first time that we have had an agent in those patients with preserved or mildly reduced ejection fraction. And this is an editorial from just a few days ago on the weekend that went with these new studies that have been published and describing the SGLT2 inhibitors as the bedrock of therapy for heart failure, regardless of ejection fraction or care setting. And so I would argue that actually we're going to see things turning around a bit. We're going to see the order of therapies reviewed as to how we go about using that constellation of therapies that we now have. And this has been proposed, and I'm going to finish with this part really to challenge us all a bit, I think, and that's including everyone who sees a lot of heart failure patients. It's how do we use all these therapies? So what we've tended to do is to prescribe in the sequence that these individual agents were tested over the years, over 40 years. So it started with vasodilators and ACE inhibitors, then beta blockers were added, and then spironolactone, and now we've got empagliflozin and dapagliflozin. But that assumes that the most effective therapy was developed first, and that's not necessarily the case at all. We also tend to titrate each drug to a maximum dose before we then add the next drug. But that assumes that those foundational therapies are only effective at higher dosages. So I think we're at a stage where it's really challenging how we use these drugs, in what order we use the drugs, and in what dosages. And so I think this is my last slide, but here's a proposal from last year from two very prominent heart failure researchers, trialists and clinicians, I would add, proposing an alternative to how we go about it. So the conventional is on the left there with that stepwise sequential addition of those individual therapies, but proposing that actually we should do it differently. We perhaps should be using beta blockers and SGLT2 inhibitors first at lowish dosages, adding an ARNI at low dose, and then adding spironolactone at low dose, and then coming back to doing the titration. So we get on within 4 weeks and have the patient on all 4 of those therapies. This is HFrEF, obviously. So that really is quite a challenge to how we think about the therapies that we use and in what order. And so I think, this is the work ahead, I think. And I think I will stop there. So thank you very much for your attention, and I'm very happy to answer any questions.
Thank you, Rob, for that fantastic update. And it does feel very up to date, having come from the weekend. So thank you for putting the effort into those slides and updating us so beautifully. I think the first question was interested to hear about the reason for the increasing rates of non-ischemic heart failure in young people. What's happening in New Zealand, and why is this such a problem?
Yeah, I think it's a really, really important question. I don't fully have the answer. I have some ideas about it. And I'm concerned, I think, about 2 major things. One of those is that we know that heart failure is the end stage of many different forms of cardiovascular disease. If we have being exposed to our risk factors earlier in life, so if we shift things back the decade, so if we have people exposed to risk factors of hypertension, diabetes, obesity in their 20s or even teens, but going back to those years, we're going to accumulate the risk earlier in life than we would otherwise have done. So that, it's a broad brush, rather non-specific answer, I think, and I don't know that's the full answer, but I am very concerned that that's part of what we are now seeing, which would make sense given the evolution of that change in our risk factor profile over decades. So the lag time would be kind of right in my eyes for heart failure now appearing. We absolutely, very sadly, have an increase in drug-related cardiomyopathies, particularly methamphetamine. And they are invariably younger people, 30s, 40s, 50s. And certainly our wards are reflective of that. So, yeah, in my career span, it would have been not so long ago that, seeing a methamphetamine cardiomyopathy in a patient in hospital would have been a relatively unusual thing. It's every week now. And then I guess the final comment I have would be rheumatic heart disease and valve disease. That in general terms has always been a smaller proportion of heart failure cases. But still we have to recognize that it's still there. So that's a long answer to a question I'm not sure that I've got the answer to.
So as far as prevention and screening for, say, first degree relatives of these younger people, if there's not obvious risk factors such as methamphetamine use?
Look, absolutely. So I think I should have mentioned that as well, that there clearly are genetic cardiomyopathies, and that will predispose people, and I think that will probably predispose people with other risk factors to then developing the cardiomyopathy. So yes, I do think that there is going to be a genetic component to our risk. There is a genetic component to our risk for cardiomyopathy, and so we're going to have to address that as a country at some stage. And clearly that is a big deal. That is screening the individual, but then it's contact tracing and screening, genetic testing, and serial imaging, etc., for family members for a long time. So, the resource implications of that are large.
As far as accessing echo, that can always be a bit tricky in primary care. We need an echo to make the diagnosis. Any thoughts about what we can do in this space?
Yep. No, and it is, and so and it's even worse at the moment on the back of COVID, unfortunately. So I think this is the case across the country. There is a severe echocardiographer, sonographer shortage. That's one thing. And then the lockdowns, etc., have put all the waiting lists long. So these waiting lists are very, very long, and that is a real issue. I would just reinforce that you don't need an echo to make the clinical diagnosis of heart failure. So it's a clinical syndrome, it's the clinical symptoms, it's clinical signs, and it's an NT-proBNP. And every laboratory in the country, every community laboratory in the country run NT-proBNP. You may not get it as quickly as you'd like, but it's a stable test taken in the community on a venous blood sample. That's the collection of what you need to make the diagnosis. Look, and absolutely fundamentally, I 100% agree you need the echo, but you can treat the person. And coming back to what we're talking about with therapies as an example, I suspect what we're going to do in the end is you're going to make the clinical diagnosis in whatever clinical context you're in. You would probably start some furosemide, and you're probably going to start an SGLT2 at that point. Why not?
Great, thank you. Just following on from the BNP comment, is there any advantage in serial monitoring of BNP to work out whether or not your medications are working, or is it a one-off measure?
Yeah, it's a really good, really good question. The number one indication is diagnosis. So I would come back to that. From a response to therapy point of view, right now, I would say no. And I'm talking about systematically across the board for all patients. And the problem with that is, how often do you do it? Are you going to stop doing something that otherwise you'd get on and do? So we know what the therapies are. We know what the dosages are. We know we've got a job ahead of us to use those therapies well. Our job is to get on and do that. And that would be irrespective of the NT-proBNP level. And I'm talking across the board for all patients. There is a role, and I think it's in difficult to manage patients where perhaps you're challenged by hypotension, you're challenged by choice of therapy, you're challenged by apparent change in symptoms that you can't work out. Where it's not going, where it's not straightforward. So yes, there is a role, but not systematically for every patient.
Great, thank you. Can you just clarify the funding for Entresto? So there's comments about it's now fully subsidised. You may need a special authority. What's the current situation, please, Rob?
Yep. Very important. So this, as we know, Entresto is for those people with reduced ejection fraction. That's defined in the special authority criteria at or below 35%. So that's a little bit lower than I've been talking about. of 40. So, but it's the reduced ejection fraction, it's symptomatic heart failure, and the criteria are for the patients on optimal therapy already, not stating what that is.
Okay.
And that's probably all I should say about that. So what is optimal therapy? It's a judgment for your patient in front of you. Have I got to the place where I want to get to with this therapy, and can I now transition to Entresto? The other requirement that was put in was that there was this persisting low ejection fraction despite those therapies, but during the early part of the COVID years we've had, that was removed, and that relates to the fact that the barrier to repeat imaging with echocardiography was too great that was not sustainable, and would have impacted on patients. So you don't need a repeat ejection fraction. So if your patient started with an EF of 34% and you've got them on good therapies, their EF could be 45% or 50%, but you don't need to remeasure it to transition to Entresto.
Oh, that's a great point. Thank you. Just a comment about access to general practice and funding. You mentioned that we may need to see people an extra 2 or 3 times to get them on optimal management. Access to GP is tricky at the moment, as is funding. Do you know if there's any thoughts as to how that can be improved?
Again, a hugely important question, and I'm really sorry that I don't have a good answer to it. I fully respect that all of you very, very hardworking GPs have been under incredible pressure in the recent years, even worse than you normally are. And for these sort of roles where, you know, there's a titration which, you know, is competing with very sick people, is really challenging. I don't know at the moment of an opportunity for funding those visits. I do think what I will say, and I'm hesitating because I am aware that there are people from around the country and the services differ around the country, but what does also need to be there is really, really good, strong nurse-led services to be able to support that titration. So that requires the training and the support for the nurse-led services. That is an evidence-based role that improves outcome. And so the nurse specialist and or nurse practitioner roles for this sort of long-term condition management fundamentally changes outcome, as we know for quite a few conditions. So from my point of view at Auckland Hospital, what used to be Auckland Hospital, our outpatient services that I lead, the titration processes are very well supervised, but they are led by the nurse specialist and nurse practitioner services. So I still think that general practice needs better support in that sort of regard for what I'll call a routine titration. So if a routine titration in primary care could be better supported, it's clearly going to free up the general practitioner's clinical time. They need to know what's going on, but the clinical time would be supported.
Yep, perfect. Thinking about Entresto, as far as starting that medication, it doesn't need to be started by a specialist, is my understanding. Can you just clarify that?
Absolutely. So the special authority is by a health. So so nurse practitioners, non-specialists, specialists, general practitioners, any doctor can do the special authority and can commence Entresto. Correct.
Great. Relevant practitioner. Yep.
Yeah.
Perfect.
That's the word. That's the word. Thank you. Yeah.
Excellent. Transitioning from an ACE inhibitor to an ARNI, how do we do this?
Yep. Very, very important. So we're still, obviously, everyone's still using a lot of ACE inhibitors. You need to pause so the patient needs to withhold the ACE inhibitor for at least 48 hours. So we literally provide written information, you know, Monday, Tuesday, don't take this drug, take the Entresto on Wednesday. We write it down on the prescription, but we give it written information to the patient on what to do. It does create some challenges because obviously many patients already at that point will have some form of blister packing or packed medications. So certainly our experience is to involve the patient's pharmacist from a dispensing point of view. And so where they're already in a blister pack, we may, and we're not confident about being able to select which pill it is, then we would have to send them back to their pharmacist. The other thing we would also do is we wouldn't where it is a bit challenging to do that withhold, we might wait until the next blister pack is being made. So if it's weekly or whatever it is, then just wait until that next pack is made, get the ACE inhibitor out of it, and then do the Entresto 2 days later. So you don't have to do it that immediate time. Talk to the pharmacist, get that coordinated, and then do it. That often is very simple and practical, and really avoids that problem. There is a move, I think, which is a sensible move, which is where you consider that your patient with reduced ejection fraction, you're very likely to want to transition to Entresto, would be to actually not use an ACE inhibitor, but to use losartan or candesartan, because there you do not need to do the 2-day pause on therapy. You can go 1 day to the next.
Perfect. Thank you. As far as renal function goes, you mentioned monitoring renal function. So firstly, is there a cutoff point where renal function is too low or an EGFR is too low to be able to start Entresto? And then what is the drop in EGFR that we need to look for? So
with Entresto, I get worried below an EGFR below 30 mils per minute, and certainly not below 20 mils per minute. Certainly not. So some people would still use at the sort of 28, the high 20s. I personally am not comfortable. So 30 is kind of my working cutoff, around about that, give or take. So renal function is important at the beginning. One of the key messages, I think, is proactively reduce the loop diuretic. So not necessarily stop it, but as you transition to the Entresto, reduce the loop diuretic. So let's say they're taking 80 milligrams of furosemide once daily at the time you've got them on the ACE inhibitor and you're going to do the transition. As you do that transition, from day one of that transition, reduce it down to 40 milligrams of furosemide. And then with that, the renal function will generally tolerate that change. The concern about renal function is where, in fact, the patient becomes really hypotensive. If you've perhaps gone to the up in dose too quickly, etc. Yeah.
Great, thank you. Just moving on to the SGLT2 inhibitors for a moment and funding where people don't have type 2 diabetes. Are we expecting changes in special authorities to get?
Yes. Yes, how fast do glaciers move? So look, absolutely, and it's really, really important. We are well behind now for patients with heart failure in New Zealand. It's simply not okay. Patients care is being compromised by not having funded access to this sort of medication. So I reread this evening, before we came online, some of the minutes of the meetings that have been held about this, and please don't get me started about that. So it does need to change. I know it is on the agenda at the various committees in Pharmac, and I hope that can move quickly. I think the Cardiac Society is making moves to promote this more. And I think what's just happened in this last weekend of new information, as I say, that picture now is irrefutable, consistent evidence. We can't do better, I think, for practicing evidence-based medicine than this situation. And we do plenty of other things in healthcare that have way less evidence. So I hope that can change. We ask all our patients now, all patients with heart failure, whether we tell them about the drug. We tell them it's not funded if they don't have diabetes, and we ask them if they wish to self-fund.
And what does it cost to self-fund?
It's about about $90 a month.
Okay.
It's not cheap.
No. Okay. So then we get into the equity issue, but we won't go there either.
We absolutely will worsen equity related issues. But we feel behoved to actually do that rather than making a judgment and looking at someone and saying, I don't think you can afford this. Yeah, I have real concerns about the equity of this.
Yeah, we talked in the weekend about using strategic use of disability allowance and what have you for medication, so perhaps there's a role there. Yes. Just wondering about dosing, Rob. We've got 2 tablet sizes in New Zealand for EMPA, 10s and 25. So if we're thinking about heart failure, where do we start? If you're focusing on the heart failure component of the therapeutic indication, it's 10 milligrams, you stop there. Okay.
So it's only if there's concomitant diabetes where you're aiming for the improved diabetes control that you go to 25.
Fantastic, thank you. There's a comment, we just tell fibs, all our patients have heart failure and diabetes. Adding some humour to the evening.
Okay, thank you, person anonymous who said that, because I didn't feel I should say that. I didn't say that either, actually.
No, it was an anonymous comment. Excellent. All right. Just some, we're in an era of COVID-19 and vaccination. So I wonder if you can comment about any adverse effects that you've seen in this space and any follow-up studies that are planned in this area.
So of COVID vaccinations, not from COVID?
Well, COVID vaccination reactions or post-COVID infection and subsequent heart failure.
Yep. So there absolutely is a, and I think everyone's familiar with it now, but there is absolutely a COVID vaccine, post-COVID vaccine related myocarditis that is particularly that is focused after the mRNA vaccines that we've had. And we absolutely have seen those in New Zealand. And we absolutely have seen some reasonably bad cases of myocarditis. They are predominantly in younger men, particularly 20s, early 30s, and don't have other risk factors that we know of for myocarditis. So it's a sort of out of the blue kind of event. And the universal view of it is that it's relatively mild and the person recovers. It's more common after the second dose of the vaccine, and generally within a few days of the vaccine. So that's the vaccine myocarditis. Are the follow-up studies? I'm not aware of. That there's post-marketing surveillance obviously going on, and there will be individual case follow-up of the people who, and I know that the Immunisation Advisory Centre had work that was going on, and I don't know the details of it, but work that was going on in relation to follow-up of people who had both pericarditis and myocarditis. So that is going on, but I haven't seen any sort of outcomes from that. And then there is also a COVID-related myocarditis, and we have seen that. So even despite the vaccination program here, and despite Omicron being a relatively generally milder illness, we certainly have seen the myocarditis directly related to COVID-19 infection. That generally occurs a couple of weeks later rather than in that initial first few days of the illness. And that's a little bit of a worry from the point of view the person can be a little bit sort of, I think I'm getting better.
And then become quite unwell. Yes, thank you. Risk factors, as far as there's a specific one that's mentioned, pelvic necrotizing fasciitis with EMPA. Can you comment on that?
Yeah, and it's really important. So the broader question of side effects of empagliflozin, fungal, genitourinary, and genital infections is probably the commonest, but still, I think it's quoted to be about 1 to 2%. Most of those are mild, and most can be dealt with over-the-counter treatments. So there's reinforcement on hygiene to try to avoid that. Serious side effects, Fournier's gangrene or necrotizing fasciitis is actually very rare, very rare. It is reported. I'm afraid I don't know the exact rate. And I guess the next years as the explosion of the use of SGLT2s with post-marketing surveillance studies will probably help us a little bit better to understand the true rate. But it does happen, but it's rare. Yeah.
Fantastic. Thank you, Rob. And just a final question, going back to the vaccination question. So the incidence of post-vaccine pericarditis or myocarditis, is it greater post-vaccine or post-wild infection? i.e., is it safer to have the vaccine?
Absolutely. Really, really important question. And the rates, and this is very clearly described from some really lovely, well, not lovely, but really well done studies from around the world during the last 2 years. So the rates of COVID-19 related myocarditis way outweigh the rate of the vaccine related myocarditis. So a magnitude difference. So effectively, that's been consistent with the continued recommendation that despite the awareness of the risk of vaccine myocarditis, that is a very low risk, and the COVID-19 myocarditis is a far greater risk, and that has remained despite it changing from Delta to Omicron.
Okay, that's a fabulous point to end our webinar. So thank you very much for your time this evening. It's been a really informative and fabulous webinar. Just a reminder that this webinar will be on our website tomorrow, along with a list of any relevant resources. Our next webinar is on measles and the potential crisis of childhood immunisations on September the 6th. So thank you, Rob, once again. It's been a wonderful evening, and thank you to you all for tuning in. Kia ora and good night.
Thank you very much.